Endocrinology in relation to reproduction. The endocrine system plays a crucial role in reproductive physiology by regulating hormone production and function. Understanding this relationship is essential for nursing students, especially in maternal and reproductive health. Key concepts in endocrinology and reproduction. 1. Hormones in follicular maturation, ovulation, and corpus luteum maintenance. Follicular maturation occurs in the first half of the menstrual cycle, primarily regulated by follicle-stimulating hormone (FSH) and a small amount of luteinizing hormone (LH). Estrogen is necessary for the continued action of FSH. Ovulation. Under the influence of FSH, about 20 Graafian follicles begin development, but only one follicle matures and ovulates. The remaining follicles undergo atresia degeneration and mix with interstitial tissue. Ovulation is triggered by an LH surge, leading to the release of an ovum from the dominant follicle. Post-ovulation changes. The ovulated follicle becomes vascularized and undergoes luteinization, forming the corpus luteum. The corpus luteum secretes progesterone, essential for pregnancy maintenance. 17-alpha-hydroxyprogesterone produced by luteinized granulosa cells. Estradiol and androstenedione produced by theca cells. 2. Maintenance of corpus luteum after fertilization. The corpus luteum continues functioning to support early pregnancy. It secretes approximately 40 mg of progesterone per day. After implantation, the syncytiotrophoblasts cells of the placenta secrete human chorionic gonadotropin (HCG) maintains corpus luteum function until the placenta takes over progesterone production. Human placental lactogen (HPL) plays a role in metabolism and fetal development. 3. Role of the placenta as an endocrine organ. After implantation, the placenta gradually takes over hormonal regulation from the pituitary-ovarian axis. The placenta produces progesterone, estrogen, HCG, and HPL, ensuring fetal development and maternal adaptation to pregnancy. 4. Endocrine changes during pregnancy. The following endocrine glands undergo physiological changes. Pituitary gland increases secretion of prolactin to prepare for lactation. Thyroid gland increases metabolic rate to support fetal growth. Parathyroid glands regulate calcium metabolism for fetal bone development. Adrenal glands increase corticosteroid production for maternal adaptation. Pancreas adjusts insulin production to accommodate pregnancy-induced changes in glucose metabolism. 5. Hormonal influence on labor and delivery. Labor is hormonally regulated by oxytocin, stimulates uterine contractions and cervical dilation. Prostaglandins enhance contractions and prepare the cervix for labor. Estrogen increases uterine sensitivity to oxytocin. These hormonal interactions lead to the initiation of labor and childbirth. 6. Hormonal regulation during puerperium and lactation. After childbirth, hormonal changes support lactation and maternal recovery. Prolactin stimulates milk production. Oxytocin facilitates milk ejection, let-down reflex during breastfeeding. Estrogen and progesterone gradually decrease, allowing lactation to continue. Clinical relevance for nursing students. Understanding hormonal regulation helps in assessing fertility, managing pregnancy complications, and supporting maternal health. Nurses play a key role in monitoring hormonal therapy, reproductive disorders, and postpartum care. Knowledge of endocrinology in reproduction is crucial for providing education to pregnant women and new mothers about hormonal changes and their effects.
Placental endocrinology. By 6 to 8 weeks of pregnancy, the corpus luteum transfers its hormone production function to the placenta. Luteal placental shift. The placenta acts as a temporary endocrine organ that plays a crucial role in maintaining pregnancy and supporting fetal development. Hormones of the placenta. The syncytiotrophoblasts cells of the placenta are responsible for producing important protein and steroid hormones that regulate pregnancy and fetal development. Protein hormones. Placental protein hormones are similar to pituitary hormones but may have different biological activity. 1. Human chorionic gonadotropin (HCG). Structure. HCG is a glycoprotein with a molecular weight of 36,000–40,000 daltons. It consists of 2 subunits. Alpha subunit, similar to LH, FSH, and TSH. Beta subunit, unique to HCG, making it useful for pregnancy detection. Functions of HCG. 1. Maintains corpus luteum function until the placenta takes over progesterone production around 6 weeks. 2. Stimulates Leydig cells in a male fetus to produce testosterone, aiding in external genital development. 3. Has immunosuppressive properties, preventing maternal immune rejection of the fetus. 4. Stimulates steroid production from both the adrenal glands and the placenta. 5. Has thyrotropic activity, stimulating the maternal thyroid gland. 6. Promotes relaxin secretion from the corpus luteum, which helps in cervical softening and preparing for labor.
HCG levels during pregnancy. Detectable by 8 to 9 days post-fertilization in maternal serum and urine. Levels double every 1.4-2 days in early pregnancy. Peaks between 60 to 70 days, 8 to 10 weeks, at 100 to 200 IU per milliliter. Declines to 10 to 20 IU per milliliter by 100 to 130 days, 14 to 18 weeks. Slight secondary rise at 32 weeks. HCG disappears within 2 weeks postpartum. Clinical significance of HCG levels. High HCG, seen in multiple pregnancies, hydatidiform mole, choriocarcinoma, and trisomy 21 Down syndrome. Low HCG, associated with ectopic pregnancy and spontaneous abortion. 2. Human placental lactogen HPL, human chorionic gonadotropin HCS. Produced by syncytiotrophoblastic cells of the placenta. Detected in maternal serum, 3rd week of gestation. Peak levels, around 36 weeks of pregnancy, 5 to 25 microgram per milliliter. Levels correlate with placental mass. Functions of HPL. 1. Antagonizes insulin, leading to increased maternal glucose availability for the fetus. 2. Increases maternal lipolysis, supplying free fatty acids for fetal energy. 3. Promotes protein synthesis through increased insulin action. 4. Enhances fetal blood vessel formation, angiogenic activity. 5. Stimulates breast growth and development, preparing for lactation. Clinical significance of HPL. High levels indicate normal placental function. Low levels suggest placental insufficiency, which may lead to fetal growth restriction FGR. 3. Pregnancy-specific beta-1 glycoprotein PS beta-1G. Produced by trophoblast cells. Detected in maternal serum, 18 to 20 days after ovulation. Functions of PS beta-1G. Acts as a potent immunosuppressor, preventing the maternal immune system from rejecting the fetus. Supports the survival of the embryo and placenta by modulating immune responses. Clinical importance for nursing students. Understanding placental hormones is essential for monitoring pregnancy progression using HCG and HPL levels. Identifying abnormal pregnancies, e.g., ectopic pregnancy, molar pregnancy, or fetal growth restriction. Managing conditions like gestational diabetes, as HPL influences insulin resistance. Providing patient education on the role of hormones in pregnancy, fetal development, and maternal adaptation.